Great. Thank you very much for that wonderful introduction. And let me take off my glasses as well and get my slides set up. Pleasure to be here. And I cannot reiterate enough what Dr. Lee said about many of the real pioneers in this field are here in Australia. And it's a privilege to have had a chance to work with many of them, including Mark Russo, Nick, and others involved there. So, introductions already been made, so let's go right to it. So we've certainly seen plenty of celebrities get their time in the press about their conditions and their struggles with opioids, opioid addiction, or opioid overdosing. But what you don't hear a lot about are the 200,000 other people around the world who die from opioid overdose, including someone like this. This is a 19-year-old New Zealand woman, Freya Stephan, who died following taking methadone after she was already taking oxycodone for her back pain. Her mom had some methadone and she didn't have good pain control, so she decided to take a little bit more. What she didn't realize at the time was that the analgesic tolerance of opioids develops very quickly in the young. And with that, the tolerance that develops to the pain control does not develop for the toxicity, so therefore she succumbed to the toxicity of the opioids. She joined a large class of folks, the over 200,000 that die around the world from overdose. And as we can see here, that the United States is #1 in opioid overdose and deaths. And that's because we consume the most opioids. We consume 99% of Vicodin, and we see here that we doubled more than what most other countries are consuming. And so it's no wonder that Dr. Hamilton Wright is quoted in the New York Times as saying, of all the nations of the world, the United States consumes the most habit-forming drugs per capita. There's only one problem. He said this 110 years ago. He said this because this was the beginning of the first opioid epidemic. He was appointed by then President Theodore Roosevelt to be the opioid commissioner and attend the 1909 opioid convention in Shanghai to reduce the usage and trade of opium in the United States. This followed shortly, the reason for this epidemic was followed by the opium wars of the early and mid 1800s. And the United States actually was involved in much of the transport and the sale of opioids in the East as well. And when it finally made it to the United States, around the time of the Civil War, there was a lot of pain from all the injuries. And doctors such as this one, Dr. John Spenders in 1874, is quoted as saying, "Certain is that the medical man who withholds hypodermic medicine from a patient afflicted with cancer is guilty of indirectly permitting a huge quantity of unnecessary pain and is totally without excuse." The advent of the hypodermic needle was made about this time, as well as isolation of morphine. And I think we would still agree with that. However, the opium made its way far beyond the medical usage. It was in all the elixirs, in Dr. Love's laudanum concoction here, and even in the One Big Cure bottle that you see here. Don't even have to list what's in the bottle. You just sell it as your proprietary information, and no identification was needed. And throughout the United States, people were addicted to opium and didn't even know it. And when they finally decided they were, the cure was morphine, or better yet, use heroin. So it wasn't until 1914 that the U.S. Congress passed the Harrison Act, which put a significant limit on the usage of opium and opioid-type products outside of medical uses. So why is it 100 years later, we're back to another opioid epidemic? Again, the largest in the world. We have the White House declaring a national emergency. Why is that? We certainly had laws. We had the advent of the DEA by Richard Nixon, created the war on drugs. We had plenty of law enforcement. We had education with Nancy Reagan proposing the Just Say No campaign. And yet, opiate usage continued to rise. Just about this same time, there was the closure of many of our medical facilities that dealt with mental health disorders. Many of those people ended up on the street and homeless. And we know now that 50% of those folks that are homeless are addicted to drugs and alcohol. We have in the United States well over 1 million people who are homeless, many of them suffering from addiction and mental health disorders. This picture was taken just a couple of weeks ago. This is in my town, just a few blocks away from where I live. This is the opioid epidemic, this is the homelessness, this is the mental health disorder that we live with. Those needles were collected in just a week by my auto mechanic has his shop across the street from this encampment. So, just about that time of the war on drugs, we also had the closure of the medical institutions for mental health. And as you see, the population plummet in mental health institutions because they were all closing. Those people moved with the increase in the laws for law enforcement for drugs. Our prison population escalated. And at the same time, we had the American Pain Society and other medical societies promoting the pain as the fifth vital sign. In fact, our Congress actually passed a resolution dedicating the years from 2001 to 2010 as being the decade of pain control and research. The American Academy of Pain Medicine promoted opioid therapy at the turn of the century. The World Health Organization issued a day of against pain and stated that pain relief should be a human right, along with the International Association for the Study of Pain. And so it's no wonder that Dr. Wen Chin here in 2001 was convicted of elder abuse, not malpractice. Malpractice has a cap of $1 million in California. But he got convicted of elder abuse for failing to provide opioids to a dying cancer patient. Does it sound a little bit like Dr. Spenders in 1874, also complaining that we should use opioids for cancer? So as we promoted more cancer or more opiate usage for our chronic pain patients, we saw an increase in sales, and that increase in sales was correlated directly with the increase in death from opioid overdose. So I like to think of this as no longer the decade of pain control, but transition into the decade of opioid deaths. And we saw that death rate escalate throughout the United States, with the blue here being very low levels of death, with the red being high. Within a few years, it spread like a cancer throughout the United States, building in tremendously the number of people who are dying from opioid overdoses. And as we recognize that usage of opioids for pain as being somewhat problematic, what we didn't recognize was that when we as physicians stopped using opioids and started to reduce our usage, that was already too late. The horse was out of the barn. And people who were then using opioids for their pain condition then had the changes in their brains go forward and start with the addiction process, and then lead to the inability to control that addiction, which then left many of them in an overdose situation. Here we see that the usage of heroin spiked after you can see the plateau of prescription opioids started to plateau about 2010, and as more and more of these patients who are now addicted couldn't get their opioids, the usage of heroin went up. In fact, it turns out that 4 out of 5 heroin usage started with prescription medications. And so even though doctors like myself are treating chronic pain with opioids, we have to recognize that it has a cost for some patients. These are the opioids, heroin users who only use heroin. There were 12 Chinese businesses selling carfentanil online for only $2,700 per kilogram, or $361 per gram here. You could get carfentanil. The Royal Canadian Mounted Police seized one shipment of 42 kilograms. That was enough carfentanil to kill every single citizen in the country of Canada. And so, while we have been discussing this with the Chinese officials who regulate drugs, they certainly have, in the last couple of years, tried to clamp down on some of these labs that are producing carfentanil and shipping it to Canada and to Mexico, which then makes its way when mixed in with heroin. But the Chinese official was asked, can you do more? He says, what we need to do is curb the demand by the United States. And he's got a point there. So what have we learned in these last 110 years? What we've learned from 2 opioid epidemics, not just one, what we've learned is that you have increased access, increased susceptibility,
increased potency, decreased cost, will give you an opioid use disorder and lead to more deaths. And that's what we're seeing. We could have predicted this 100 years ago. So while the legal system sort of complained that Dr. Chen here didn't give enough, 15 years after his conviction, we now have the conviction of Dr. Singh in 2016, the first doctor in the history of the United States to be convicted of murder. 30 years to life for murder. Did she inject it? Did she administer it? No, she did not. All she did was write a prescription. That got her 30 years to life for murder. So, what it leaves us pain docs with is a dilemma. Damned if you do, and damned if you don't prescribe opioids. Or in the words of our illustrious president, nobody knew healthcare could be so complicated. We still have over 116 million people in the United States that live with chronic pain. And so the Congress commissioned a study by the National Academies of Science and Engineering and Medicine, and they found that this is their dilemma. Finding the balance is a challenging task, but they did promote the usage of non-opioid therapies, including spinal cord stimulation, in their 400-page document. Certainly, even our leading scientists are promoting it, but our insurance carriers, our insurance policies, and our medical systems are not really utilizing spinal cord stimulation and other neuromodulation therapies early enough. In fact, they usually reserve it for the very end of an algorithm, a ladder-type algorithm. And in this algorithm, the time from diagnosis to consideration of spinal cord stimulation is usually measured in years. Most of the studies that have been published that we talked about earlier today, and we'll talk about in the future, the average length of time, including the one that was done here in Australia, between the time of diagnosis and the time of allowing that therapy to be offered to patients, ranges between 8 and 12 years. Far too long for our patients. Usually these patients are already on high-dose opioids. And so Dr. Levy and I and other members of the INS and the medical community have written a series of papers on when is the right time to offer neuromodulation therapy. And as Mark was mentioning earlier, you have to actually consider a variety of issues: the safety, the appropriateness, the physical neutrality, and effectiveness. Mark mentioned several times that oftentimes the physical neutrality is at 2 years, but often sooner as compared to other therapies. The safety, while infection might be an issue up front, it certainly doesn't compare to the devastation that chronic opioid therapy has for many patients. So while we call this an opioid crisis, it's really a healthcare crisis, a crisis that requires a comprehensive healthcare solution. And the Surgeon General of the United States, whose brother also has a mental health disorder and is also opioid addict, is struggling with getting the same resources for his own brother as the rest of us for our patients. And he's promoting that we work together in more unison to provide better partnerships and better opportunities for our patients. I'd like to shout out to Dr. Peter Boyles, a pharmacist down in Tasmania, who has actually taken this approach and actually utilizes to formulate a comprehensive treatment strategy for the patients in that region. And in their healthcare plan, that once you reach a certain level of opioid prescription, your chart gets reviewed by the pharmacist, the pain physician, and the addictionologist. That work is ongoing and is quite impressive, and something that I am hopeful that will spread throughout the world. So we come back to Freya. Could she have been helped by neuromodulation? Could she have survived? We won't have the answer for that. But we do know that by working together, utilizing all of our alternatives, including neuromodulation therapy, we can help patients with chronic pain avoid opioid overdose and deaths. Thank you very much.
The other side of the argument. So let me just quit out of this. So we have this terrible problem, but one of the questions is, if opioids don't work so well, why are we still prescribing them? And why aren't we using neuromodulation? Sorry? So I'll move through this rather quickly, but I think that this is the second part of the punch that we need to get across. That is, everyone knows now how horrible opioids are. And what is amazing is that for 30 years in the United States, we were all trained that opioids aren't dangerous. If you're treating a chronic pain patient, they don't get addicted. And you just keep going up on the opioids until you get pain relief or side effects. That was dogma. And yet it was wrong. And so we know that despite their increasing use, opioids don't work for the treatment of chronic pain. Every study, every proper study, as Sally said, it's proper medical evidence that needs to drive us going forward, not just people spouting off, as many doctors do. And in every careful study that's been done, opioids don't work for long-term pain control. They don't work. Plus, they have these horrible side effects. And it's not just addiction and death. There's significant heart problems, lung problems, endocrine problems, sexual dysfunction, depression, as well as overdose and death. And so we have been stupid as a medical establishment to continue prescribing high-dose opioids for chronic pain. And so, and the evidence behind this, for example, was one of the only randomized controlled trials, translate that into good medical evidence, of this study that was published just last year. And it was looking at patients who had chronic back pain or hip or knee osteoarthritis, and they were treated with opioids or non-opioids. And what you saw is that people didn't get better relief at all from the opioids than with ibuprofen, just an anti-inflammatory. So no better relief, and yet a significant increase, even though that doesn't look big. Statistically, that's very big, difference in complications. And the complications were severe. We're not simply talking about getting a little drowsy from an opioid. We're talking about dropping dead from an overdose. So we know now, opioids don't work. That's not to say that we don't put people on a lot of opioids and that they don't develop problems with tolerance and addiction, but we shouldn't. And so why are we still using them? We shouldn't. That is, unless there are specific circumstances to justify it, we should consider a neuromodulation procedure. My job is to convince you why in 10 minutes. Okay? This is, I believe, this not-so-hidden cure for the opioid crisis. And when I say not so hidden, we haven't done a good job in explaining it to everyone. We haven't done a good job in propagating it, but it's been right in front of us now, as you've heard, for almost 50 years. This is Martin van Cleef. Martin van Cleef is from Maastricht, and he showed now almost 20 years ago in a randomized controlled trial, highest level of evidence, that if you use spinal cord stimulation and physical therapy, it works much better than physical therapy alone in patients who have what is now called complex regional pain syndrome, but back then was called reflex sympathetic dystrophy. Proven. Absolutely. No question about it. This is Chris Kumar from Canada, and he published this article now about 12 years ago before he passed away, showing that if you look at control, this is the highest level of evidence, if you look at patients who had back surgery and compare those that were treated medically and those that got a spinal cord stimulator, that there was an overwhelming difference, highly statistically significant, not only in terms of the degree of pain relief and patient satisfaction, but also in costs for the government. This study, with those data carried out for 24 months, so we know even 2 years later, patients were doing much better if they had a spinal cord stimulator than if they were treated just in a medical pain clinic. This is Richard North, who is actually going to be receiving one of our Giants of Neuromodulation awards at this meeting. And he demonstrated, and one of his biggest contributions to the field is that he took a population of patients who'd had a back operation before and randomized them to either getting another back operation because they weren't doing well or getting a spinal cord stimulator. And as you would expect, it did profoundly better if you got a spinal cord stimulator as compared to another back operation. In fact, the rate of success with another back operation was painfully low, as Mark mentioned, on or around 0. And yet a significant percent, 2/3 of the patients, got excellent relief with spinal cord stimulation, and it was cheaper, and patients had more satisfaction. So why do we send patients to get yet one more spine operation when a spinal cord stimulator has been proven, high level of medical evidence, to be a better approach? This is Leo Caparol. Leo's here at the meeting, and he looked at a newer therapy. As Mark said, we're getting better and better success rates. This is using a new type of spinal cord stimulation that works somewhat differently and where you don't feel anything. And he reported that 80% of his patients got excellent pain relief as compared to those that were treated with an older method of spinal cord stimulation. This is, again, following those patients not for a week, not for 3 months, but for 2 years. And there's now 3-year data that shows the same thing. This is Dr. Tim Deere at the meeting and me, who looked at a type of stimulation just outside the spine in a part of a nerve called the dorsal ganglion. And again, these are patients who have complex regional pain syndrome, or RSD, and showing that 80% of our patients got wonderful relief as compared with only about 50% of patients who got spinal cord stimulators. So a different type of neuromodulation that may work even better. And this is Dr. Ash Sharan, who is in Philadelphia, who showed that if you use spinal cord stimulation, then you can significantly decrease opioid use. And if the spinal cord stimulation gets turned off, or if it's not working anymore, patients go back on their opioids. So as you expect, you can control opioid use with effective therapy. This is a study that was done by one of the companies, but externally validated, showing that if you get people early, they do better with spinal cord stimulation. So if they're taking little or no narcotics, in the long run, only about 5.5% have their devices fail over time. But if you wait until they're on high doses of narcotics, then a lot more fail. And so the earlier we can get to patients, it seems the better we can give them pain relief. So it's almost as if not only do the opioids not provide great relief, but when people have been on opioids for a while, we're less able to help them. We'd like to get to them earlier. And this is a study that was done using a new type of stimulation, and that specific isn't important, but they basically looked at opioid use with this spinal cord stimulation. And these are the different kinds of pains that the patient had, which is the usual breakdown of pain problems in the United States. The patients had had pain for a long time, 13 years. And yet, if we look at those, we see that those who started out on narcotics, on opioids, within 12 months, they were down to 2/3 as much opioid usage. That is, and a quarter of the patients had a lower dose of opioids, but even more importantly is that, I'm sorry, thought I had another slide in there, the percentage of patients who actually were able to stop opioids. So this is a different way of looking at that same data. Half of the patients were able to decrease their opioids, and half of them weren't, but those half were able to significantly decrease their opioid use. And at the end of 12 months, over a quarter of the patients were off of all opioid medications. So we can use spinal cord stimulation as a way of getting people off of opioids and hopefully preventing them from having the horrible complications. I think I'm going backward. And then, just to finish, this is called the number needed to treat analysis. This takes into account how many patients you need to treat with a given therapy before somebody gets a home run. And as you can see, if we're looking at this mode of spinal cord stimulation, you have to treat about 1.5 patients to get one who's successful. Or since we can't cut patients in half, if you treat 3 patients, 2 of them are going to have a significantly positive response. But you have to treat somewhere between 4 and 60 patients with opioids in order to get one real success. So you look at that and say, why in heaven's name are we prescribing all those opioids when it's much more successful to use spinal cord stimulation? And even more compelling is called a number needed to harm analysis. So this looks at people who have bad side effects. And if you look at spinal cord stimulation, you can see that you can implant on the average of somewhere around 70 patients before one has any kind of side effect. Whereas if you're treating patients with strong opioids, by the time you get to 10 or 12 patients, you're already hurting somebody. So if you take that number needed to treat and the number needed to harm together, you throw up your arms and say, we've been doing this all wrong. And so what we are trying to do is we're trying to convince people that the old dogma is wrong. Chronic opioids are not safe. Chronic opioids should not be one of the first things you think about. In fact, chronic opioids don't work and they hurt people. And so we should at least consider using neuromodulation therapies when they're appropriate before we would ever put somebody on chronic opioid therapy. And so this is our journal, and this is where all the stuff gets published. And I'm just honored to be here in Sydney for us to be able to spread this information and learn about the cutting edge. So thank you very much.